Hello, I'm Benedict Michael. I'm a senior clinician scientist fellow and a consultant neurologist working on brain infections and the NIHR HPRU for emerging and zoonotic infection here in Liverpool. And I'm here to talk about COVID-19 and its effects on the brain. And I'm conscious that when I do this, I'm very much standing on the shoulders of giants. And this is, of course, a wonderful picture of Konstantin von Economo, who did so much great work during the 1918 Spanish influenza outbreak. And the effects of pandemic viruses on the brain is something that we've been aware of as a neuroscience community for a long time. And my work on it first began back in the H1N1 pandemic, where we ran a prospective study over 2 years, looking at these through the ABN and through the BPNA, and found that only 25 cases, predominantly in children, many PCR positive in respiratory samples, but none in CSF. And of those patients, the majority of them had encephalopathy or encephalitis, but really quite small numbers given the fact it was a UK-wide study for over 2 years. But this information and our experience and information in the literature made us primed to be aware of what possibilities might come as the virus SARS-CoV-2 started to spread across Europe and North America from China. And we've seen different pathophysiology. We've seen breakdown in the blood-brain barrier and sometimes virus entering the brain in some viral brain infections. We've also seen para-infectious cytokine storms, so where the virus is detectable in a non-CNS site, such as a respiratory sample. And we've also seen post-infectious, often antibody-mediated complications due to viral infection. And we now recognize that up to 70 to 80% of patients who are hospitalized with COVID will have some sort of neurological symptoms. Up to 10% will have some sort of neurological syndrome, such as encephalopathy or delirium. And up to 1% will have a specific neurological diagnosis, such as encephalitis or transverse myelitis. And of course, we've seen with SARS-CoV-2 not just the processes of which we were well aware, but also that the virus can induce an endotheliopathy or a vasculitis that can result in cerebrovascular events. And this combined has led to a call for a global COVID neuro research coalition. But of course, when we think about the impact of viruses on the brain, we have to think about what the likelihood is that the virus is actually having a pathogenic role here. And clearly, if we can identify the organism within the CNS or an intrathecal immune response, then that's our highest association in terms of likelihood of causation. But actually for SARS-CoV-2, for the majority of cases, we're identifying it not in CSF or brain, but actually in non-CNS sites. And the arguments for and against are that, well, certainly for, it's consistent with what we know from other viruses like H1N1. It has a temporal association with infection and neurological manifestations. It's certainly biologically plausible and coherent. And there's some early experimental evidence. But there's arguments against it, of course, because the strength of association seems weak. A great many, hundreds of thousands of people have been infected with the virus, and seemingly only small numbers of patients develop neurological problems. And of course, it's not specific. We've seen this with other viruses, but it seems to be happening consistently. But one of the other problems is that, of course, there seems to be little in the way of a biological gradient, i.e. it's not those patients with the worst COVID-19 disease that necessarily develop the neurological complications. There's a great many unanswered questions, and we set out to start to try and answer them through the coroner studies, which is a collaboration between the UK's major professional neuroscience bodies, including the ABN, the BPNA, the British Association of Stroke Physicians, the Neuroanesthesia Critical Care Society, and the Royal College of Psychiatrists, among others. And the study was set up in a very simple way so that busy clinicians on the front line could notify us of a case within just 2 to 3 minutes of completing an online form. And then we would recontact the doctors and invite them to give us some detailed data on the patient via an anonymized case record form. Our first paper was published in the summer of last year on the first 153 patients through this UK-wide surveillance study. You may have caught the paper or perhaps some of the media coverage of it. And what we found in this study was that the patients reported through our surveillance portals seemed to broadly match geographically those cases of patients being hospitalized with COVID at the same time. And in doing so, mobilizing quickly and with great thanks to our colleagues, we were able to actually recruit patients to the study through the phase of the pandemic. These were the 153 cases, approximately 2/3 with cerebrovascular events, which was increasingly recognized at the time. But interestingly, a third with alterations in mental status, which Dr. Tim Nicholson will be talking about in his talk. And whilst our cohort skewed perhaps slightly older in comparison to generalized cases of COVID-19. What was really striking was that these patients with altered mental status were, although occurring at all ages, often occurring in younger people, with 50% occurring in people under the age of 60 and about a quarter occurring in people in their 20s, 30s and 40s. We've gone on to continue to run the study, and we've got just over 700 notifications now, but we've looked in detail at 500. Again, cerebrovascular events and altered mental status predominating, but also interesting cases such as cases of meeting our clinical case definition for encephalitis and a few cases of meningitis. We've gone on to look at our notifications over time during the first wave of the pandemic. And the light grey line here shows you just generalized hospital admissions with COVID-19 during the first wave. And what you can see in the dark line here is that while stroke cases were the vast majority of what we were being notified of early on in the pandemic, over time, the number of stroke cases has declined along with the declining number of COVID patients in hospital. But conversely, as a proportion of cases which were notified to us, there's been a gradual increase over time in patients being admitted with alterations in mental state. We've gone back, as I say, to the physicians to get detailed case record form data on those patients, and that paper is currently under consideration, but is available on SSRN as a preprint. In this detailed study of 267 cases, we split them first neuroanatomically, identifying that 226 of those cases were central manifestations as opposed to peripheral. Then by pathophysiology, again, predominantly cerebrovascular cases, but also cases of CNS inflammation, delirium, and primary psychiatric disorders. And if we look from the time from symptom onset to the time to developing neurological symptoms, you can see that the cerebrovascular events had a median time of onset of about the same time as the onset of respiratory symptoms. And this was statistically significantly earlier than those patients presenting with central inflammatory, psychiatric, or peripheral neuropathic presentations, suggesting perhaps a different pathophysiology, suggesting in fact perhaps that the cerebrovascular events are a para-infectious or a directly infectious process, whereas central inflammatory, psychiatric, and neuropathic presentations may represent a post-infectious cytokine or antibody or other host-mediated response. And when we looked in detail at these cases, we found that the cerebrovascular events were predominantly ischemic events, but also cerebral hemorrhages and cerebral venous sinus thromboses. And we went on to classify those patients not just by their primary diagnosis, but also by where they might meet multiple of the a priori clinical case definitions, really showing this complex interaction between these different potential complications. For example, there were patients who had a cerebrovascular event, who had symptoms consistent with delirium, but also had a central CNS inflammatory disorder. But what was interesting was that beyond delirium, which was common, there were cases of a clear psychiatric diagnosis that would not meet the criteria for delirium. So beyond the pathophysiology I described, we're now increasingly recognizing that whilst there might be para and post-infectious immune-mediated processes, there may also be a role for the acute stress response to the pandemic, and of course being hospitalized with COVID, which at the time was a very poorly understood disease, with doctors in full PPE, with all the socioeconomic pressures and all the stresses of being hospitalized, and the impact that might have, which Tim will speak to more. But focusing neurologically, the two cases I wanted to focus in on were the cerebrovascular events, because they were the most common, and the severe encephalopathies, which were of interest. Now, we had 13 cases of very severe encephalopathy, which would not meet the 5 societies diagnosis of delirium. These patients had very severe reduced levels of arousal, often with cardiac and renal complications, including cardiac arrest. We identified patients having seizures in older adults, often with significant pre-existing neurological comorbidities. But we also identified this group of younger patients presenting with seizures and status epilepticus as a de novo presentation with no premorbid conditions. And what's critically important about these patients is that they were younger and they had higher rates of in-hospital resource utilization, often requiring longer durations of ventilation and increased likelihood of needing intensive care support. We then compared the cerebrovascular cases to the SNAP cohort of non-COVID stroke patients who were hospitalized during the same time period, but during 2019. And when we compared the non-COVID stroke patients in grey to the patients in our study, we saw that the COVID-19 stroke patients skewed to being a younger population, being twice as likely to be under the age of 60. And then when we looked at this group, actually what was particularly interesting was that not only were they younger, but they also had a higher frequency of non-CNS thrombotic complications, such as pulmonary emboli, cardiac thrombus, or renal artery thrombus, than the rest of the cohort. But despite being younger, they often had high rates of other cardiovascular risk factors, such as congestive heart failure, hypertension, diabetes, cerebrovascular disease, or atrial fibrillation, suggesting that there may be a group at high risk, even though young, due to conventional risk factors. But despite this, whether we adjust for the diagnostic variable or not, the two most consistent and significant predictors of poor outcome were age, with an odds ratio of 1.66 and 1.67, and clinical frailty score prior to COVID-19, with an odds ratio of 1.48 and 1.51 respectively. But clearly, we have some sense of the clinical characteristics, but the disease mechanisms of these acute neurological complications remain largely unresolved. We don't fully understand who's at risk, and we don't really have a good handle on the medium-term sequelae. And that's why I'm delighted that the UKRI have funded our COVID CNS study, of which I'm the co-PI. And through this study, we're going to assess patients face-to-face and online for neurological symptoms and signs. They'll undergo a cognitive battery of testing, and they'll complete psychiatric assessments also. And then we'll compare these clinical assessments with structural and functional MRI, with blood markers of brain injury, with their cytokine, chemokine, and autoantibody profiling, and in those patients that sadly pass away, perform post-mortem analyses that are both immunologic and virologic. So I'll conclude there. I think our work and the work of others has demonstrated that COVID-19 is associated with a broad spectrum of potential complications throughout the nervous system, that outcomes vary between disease groups, but particularly by pre-COVID status, determined by age and clinical frailty. And we have identified these groups with a severe encephalopathy, often requiring intensive care and ventilation, and often with seizures beyond what would be expected for delirium. That these people with large and multi-vessel strokes, often occurring in younger people under 60, and often occurring with non-CNS thrombotic disease, which clearly requires further study. But that conventional and sometimes modifiable risk factors were associated with young stroke is a potential for a huge public health intervention. But with our future work, not just these clinical data, but also our biomarker and neuroimaging data, we hope that we can stratify patients mechanistically to existing or novel targeted therapies. And whilst there remain a great many unanswered questions, unlike back in 1918 with von Economo, working now together across the neurosciences, we might finally answer these questions. It's great thanks to the COVID CNS study of RAs, clinical research fellows and postdocs. Thanks also to the postdocs, PhD fellows and other members of the team involved in all the neuroinfection education, and of course the coroner study group with whom the whole thing got off the ground. Thanks of course to the professional neuroscience bodies, and thank you all for listening, and thank you for the invitation. I'll now hand over to my colleague, Dr. Tim Nicholson.
Okay, so thanks, Ben, and my name's Tim Nicholson. I'm a lecturer in neuropsychiatry at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and I'll be adding a bit of detail about the neuropsychiatry and psychiatry of the work we've been doing together and the broader picture. So I'll add a bit more detail about the psychiatry data coming from the coroner study, talk a bit about the broader context of the evolving literature on COVID-19 neuropsychiatry, touch briefly at the end on long COVID, which I think, as many of you will be more than aware, is a growing and important clinical problem of interest to us in neuropsychiatry. So the coroner study, it's been one of the silver linings of the pandemic, has been the response of the scientific community and the joining up of the clinical neurosciences to work together to address this sort of urgent clinical and sort of world-dominating problem. So I think the great thing about Ben and his team is they got their study up and running straight away, thanks to the foresight of planning for such an eventuality. And within psychiatry, we started thinking about doing a similar surveillance system until we realized that this is already up and running, and working together was clearly a no-brainer for all of us concerned. So together with colleagues at the Faculty of Neuropsychiatry, we got the psychiatry reporting system that Ben's mentioned to you up and running quite quickly. I think we started getting cases in May, and this is the first paper that Ben will have mentioned to you, and 23 psychiatry cases were reported in the first 153 notifications. So just getting into the detail of the psychiatry side of things, as Ben would have mentioned, within the neuropsychiatric disorders, we had 23 cases, some psychosis, neurocognitive dementia-like syndromes, and a mixed bag of other psychiatric disorders. And those others were 3 cases of depression, 2 of personality change, 1 of catatonia, and 1 of mania. And at this stage, the notification phase, we were relying on clinicians reporting and their clinical judgment on what and these were normally experienced clinicians, about what their judgment of the primary psychiatric diagnosis was. And as Ben would have mentioned, we then went on to get more detailed information through the case report form, where we could dig down into the detail. And this is the first 267 cases where we got full CRF data, and the new psychiatric diagnoses, primary psychiatric diagnoses, are nested here within this larger flowchart. And just focusing in on this, we've got 6 were, when we got the full details, were exacerbations of existing psychiatric conditions. 19 were new diagnoses. And this is the range of predominantly psychosis, but with some depression and anxiety, and a miscellaneous group of other disorders. And when we look at the classifying the overlap of these syndromes, as Ben would have mentioned, the data could be split by various different, whether it's central, peripheral, different mechanisms, or anatomical issues. But when we look at the psychiatry cases, there was some overlap with delirium, as we would expect, and some with inflammatory disorders as well. So I think we're now going to dig down and analyze this data even in more detail, and this is research that's underway as we speak. So we're going to give some more detail now about the evolving literature and the context of all this. And one of the other positives of what's been going on in the last year has been helping to put together a large group of an increasingly large international group of people who've set up what is a sort of a weekly updated blog on the neuropsychiatry of COVID-19. And Matt Butler and many other colleagues have done amazing work at putting this together, and many of you will hopefully have seen this, but if not, please look at our website and follow our Twitter account, which has a multi-talented team, including Bakers, who made this Shrove Tuesday coronavirus themed picture for us. So here on the blog, we have weekly updates of highlights of the best, we think, are the most interesting and important papers in the last week. This is published every Tuesday evening normally. And then there's a news in brief, case reports, and then a big database of other of all the key topics and subtypes of paper that people would be interested in. And we're about to overhaul the whole blog and make it more searchable and user-friendly. The team also do these webinars on the Brain Infections Global monthly webinars, and so all of our sort of stellar team do a 5-minute 5-paper review, and there's some great sort of run-throughs of key papers if you're interested. The team have also done the plan has always been to try and do a living systematic review, but that's no small feat to pull off. So the first part of this has been a review search date at the end of the summer, looking at the whole of neurology and neuropsychiatry of COVID-19 with a systematic view and meta-analysis. And this was inspired by Ali Rooney, with amazing work from Cam Watson, an academic FY at Queen Mary, and Jonathan Rogers, a PhD student at UCL. So this is the data so far, and obviously this is mostly data of the acute presentations rather than longer term complications, but putting together all the neurology and psychiatry and organising it by point prevalence from the data as it is so far, this is what we have. So this is the preprint that's just come out, and I'd recommend you look at that, and hopefully that'll be published reasonably soon. So the emerging database has really shown increasing study quality, as you'd expect, and this is just a plot of that we get more studies and fewer case reports and more cross-sectional and high quality studies. April, there's is dropped down because this will be much larger if you look at it now, but this was because the study, this is when the data collection started for studies that at the end of the summer. So this will continue to grow exponentially as we'd expect. I think one other paper just to quickly highlight is a preprint from an Oxford group who've analysed a large US data set, which has provided quite a lot of evidence from the epidemiological point of view about the rates of neurology and psychiatry conditions. And took a very broad approach with ICD-10 diagnosis classified by electronic notes recordings with all the attendant limitations of such data, but it's a very large data set, as you can see here. I think there are some things which confirm what we've already seen, is that stroke rates are higher, but some reassuring evidence about Parkinsonism, Guillain-Barré, and other syndromes that potentially, could have been some concerns about. But I think it also flag up dementia, hazard ratio of 2, psychosis, hazard ratios of 2 as well. And the sort of one surprise has been this myoneural junction muscle disease category, which potentially might reflect post-ITU myopathy, and we'll wait to see when the paper comes out, hopefully soon, what discussion is made of that. So just to bear in mind the causality issue that Ben mentioned, and this is the paper that he and other Mark Ellil led on, really discussing that in JNMP, and I think it's really nice, and just a reminder of the sort of the key issues about causality we have to bear in mind with any association. So where are we at now? So I think we have strong evidence of stroke, delirium, and PTSD. There's a few other conditions which may or may not be associated. We have a sort of chart system where things are going up and down. Initially, Guillain-Barré syndrome, there were some concerns about, but there's been quite a lot of reassuring data that that's perhaps more association rather than causation in any cases people notice. I think we're still quite interested in catatonia and other disorders like psychosis as to whether these, and potentially cognitive dysfunction in the form of dementia, potentially being at risk later on. And then also, where does long COVID fit into all this? And this is a very interesting condition for many different reasons, but it's the way in which this has been a patient-led research. It's been sort of revolutionary in that sense, that these patients coalesced over the summer really on a Slack group, a sort of app for organising work streams, and these patients would sort of describe and share their symptoms, and they reported their own symptoms on a Google Doc in May last year. And then this was picked up by the media, and most notably by Ed Yong in The Atlantic, and really kickstarted a whole media awareness about this condition. And the patient-led research has really kicked on from there. And this is a preprint of the first nearly 4,000 patients who reported their symptoms, and was analysed by a couple of Athena Akrami and Hannah Davis, patients with long COVID. And Athena is a neuroscientist at UCL. So this is brilliant work, really documenting the full extent of the symptoms which they had, and a lot of cognitive dysfunction as part of that, which would be of interest to many of us. So this is the range of symptoms, a huge range of different symptoms that patients had, and notably there wasn't much testing available, so only a quarter of these were positively diagnosed on PCR. And of interest to us, neurological symptoms are common. So beyond the brain fog and fatigue, which is quite people are very aware of, I think dizziness and other symptoms I think are going to be quite important clinically in this population. And this is a paper we're putting together to reviewing the whole field, and there are lots of complexities around the definitions, the features, and the mechanisms, and it's still a bit of an unknown issue. But this is hopefully puts on one figure the key persistent problems that we've got in what we're dealing with, grappling with this complex disorder. So how long do you need the symptoms for? What evidence do you need of infection? And that obviously depends on the availability of testing as well. What are the symptoms? What clusters are going to be subtypes, subclusters, and perhaps that feeds into different mechanisms that we might have at play as well. Another key issue is really whether it's really going to be just community patients we're going to mean by who don't have an acute initial illness that we mean by long COVID, or whether we're going to keep rolled into that the group who had initial severe disorder, but for whom there might be a more obvious explanation as to why they've got chronic symptoms. And this, just to put it in the context of the post-viral syndromes in general, SARS and MERS caused a lot of chronic myalgia and fatigue and PTSD and other psychiatric symptoms, and as do most of the other viruses, can have these sort of long tails. And obviously, with just the scale of what we're seeing with long COVID, it is particularly striking. So I'll just wrap up there to thank the coroner of neuropsychiatry team led by the Faculty of Neuropsychiatry and all these people that will be familiar to, and the COVID CNS team. And it's fantastically led by Jerome Breen and Ben Michael, and it's a brilliant interconnection of clinical neurosciences across the UK. And the first patient was recruited last week at King's and one this week from Liverpool. So I'll just finally say that we're open to offers for people to join our blog team, and we'll be at all levels, whether it's juniors or seniors. We need people at all levels to help out with this, and it's a great and dynamic team. And then finally, just thank those who've reported cases on the coroner surveillance system, but to encourage you to continue to notify and fill in the CRFs. And we're now interested in vaccine complications as well. As many of you would have seen, there are some potential functional reactions to the vaccine on social media, and we're very interested in you reporting those. So with that, I'll thank you for your attention, and we'll be open to questions after this.